experience in multiple subspecialties. This is her second time presenting at the Appendix Cancer Symposium, also has spoken at SSO and other national events, and is also an active participant in all our research and clinical efforts. So Emily, the floor is yours.
Thank you. Today I'm going to talk about managing cancer and how to leverage your oncology team. It can be a very turbulent process of endless appointments and long hospital stays, test procedures, blood work, unanticipated aspects of cancer care. Family and the steps needed to effectively treat your cancer cost a lot of money. It requires a lot of traveling. So a diagnosis of cancer means all these additional things that increase the burden you and your families already face, all as you're just trying to deal with the simple fact that you have cancer. So recognizing that, I want to take a few moments to talk about how to approach this journey of cancer care, navigate the stress of it all, and help familiarize you to the resources that might be available to you. Next slide, please. So it's important to know who is on your team. And once you have established with your preferred cancer center, make sure you ask who else is available on your team. At University of Chicago, our patients routinely meet with myself, an advanced practice provider, and dietitian, as well as the doctor during their clinic visits to ensure we're closely following any medical issues and addressing nutritional deficits early, but before they become a serious problem. However, if you don't ask what resources are available, you may not know that a physical therapist could see you to talk about your leg swelling from lymphedema, or that you don't have to suffer from nausea or painful neuropathy from chemotherapy. In that case, you may benefit from meeting a palliative care physician who doesn't just manage end-of-life issues, but is a valuable member of your team who focuses on your symptoms and your comfort during treatments. Remember, if you do have a surgical concern, your surgical oncologist team is the most appropriate to reach out to, while things like chemotherapy, side effects, and medication know about a particular problem you're having, it is difficult to help you. So my advice to you as a patient is please don't hesitate to bring up concerns you're having to any member of the team so we can support you in every facet of your care. One common myth, I think, is emotional support. While your doctors and your care teams are empathetic to you and how difficult it is, are there.
Emily, I'm going to pause you for just 1 minute. I think we're not able to hear half of what you're saying. There's like some significant disturbance that's happening when you're speaking. So I don't know if it's the network or the connection. I don't know if it's just me, but are you guys also all hearing that sort of interruption? Yeah. So I think, Emily, it might be worthwhile for you, if you don't mind, let's kind of, if you don't mind, we'll have you kind of readjust your position. Maybe if there's a different location you can go where we can get better internet. In the meanwhile, maybe we can move to our next speaker if that's okay with everyone. And then we'll come back to you, Emily. I'm so sorry about that, but I just think it's like persistent and I couldn't tell if I was the one with the bad internet or you. So, so hold on for a little bit. So I think while Emily is trying to relocate and find a good location for the internet, I think I'd like to introduce our next speaker. Kevin is actually one of our newest members of our team. One of our other nurses, Jen, sends her regrets that she's not here joining all of you, but Jen Belansky and Kevin have been integral to our program, and they are usually the face, the folks that you would interact with and you interact with us. But Kevin is going to speak a little bit about how to identify the right educational resources when you're looking online or on the internet.
Thank you very much. Thank you for inviting me to speak today. I personally feel that education is important because it empowers patients to speak up and be the best advocate for themselves and for their families. Slide, please. So while Dr. Google can seem like he knows everything, it's important to remember that it is a tool that can be useful in finding information with varying degrees of validity. Oftentimes this information can increase the amount of stress and anxiety that we have because of the vast array of information provided from a single search. For this reason, we want to look at a few things when navigating the internet. Firstly, we're going to look at author credentials. When looking at author credentials, you want to ask yourself whether or not this person is the appropriate person to be writing about the subject at hand. You know, do they have the proper credentials and are they qualified? Secondly, are you able to find additional information about the individual online? Next would be domain. Domains like .gov and .edu tend to be more regulated than those ending in .org or .net, .com. This isn't to say that they don't have valuable information. It's just that sites like Wikipedia and WebMD should be viewed with a little more caution when compared to other sites like clinicaltrials.gov or NIH.gov, which are both wonderful tools for obtaining information on current available trials. Sometimes the wording on those lower quality sites can be written in such a way that information can be interpreted in a way that wasn't intended. In addition to that, you know, these are the reasons why it's imperative to remain vigilant as to the type of domain each site is when gathering information. When looking at accuracy, you want to ask yourself what sources are listed from the information that was obtained, whether, you know, looking at the bibliographies, the works cited, you want to be able to go back and self-verify that information yourself. And are you able to verify those listings from your own search? If not, you know, you may have an issue. Reliability. When evaluating reliability, you want to ask, why should we believe the information from this site? What institutions support the information provided? Some institutions are more reliable than others, universities or government agencies being some of the best. Dates of publication. When evaluating publication dates, you should ask whether the information is more than 5 years old. If it is, there's likely newer information available. If no date is provided on the document that you're reading, you want to check for when the site was last updated, which will clue you into how up to date the information truly is. By using these tips, you can better ensure that information obtained online is factual and valid. And remember to always feel free to reach out to Jen or myself if you have reservations about certain information you find online, regardless of where you're getting your care. We're happy to assist you in any way possible. Thank you for your time.
Thanks, Kevin. And Pujitha, if you don't mind, if you could just share contact information for you know, Kevin and Jen, so that folks that want to connect with them, they can. And I think I would strongly echo that, you know, it's important to use reliable organizations, you know, things like ACPMP, the government websites, to just make sure you're getting the right information. And specifically when you're reading about prognosis, I think it's very important to be able to discuss that with your physician team, just to make sure you get the right information there. So I think we have Emily back on the line. So Emily, round 2 for you.
Okay, how is my audio now? Can you hear me okay? So hopefully you can, and I'll move. Okay, so really just to summarize the oncology team, you know, there are a lot of valuable members on the team, and I think patients are surprised by how many resources there really are available to them. And the best way for us to know to help you is if you share your concerns that you have with us. So please do that, and we'll help you navigate what the resources are and connect you to the right ones. Next slide, please. Let's talk about care surrounding surgery. When you have the appropriate expectations and some knowledge of what is to come, it helps you better manage your cancer, and to know what types of questions to ask your care team. So when surgery has been recommended to you, the team will guide you through a number of tests or additional consultations you'll need to complete. It can feel tedious, but remember the goal is to give you the best possible surgical outcome. So if you don't prepare for race day, you may finish the race, but it could have been a lot easier on you if you had prepared as well as possible for that. And so for that reason, our program has surgical patients meet with our physical therapists and our dietitians before surgery. They help instruct you on how to optimize your strength with exercises, optimize your nutrition with diet to ensure the best recovery from surgery possible. If you don't have these resources at your cancer center, I do encourage you to seek that out and incorporate a healthy diet and exercise into your lifestyle now. It does make a difference. Let's talk about after surgery. For our patients with appendix cancer that is spread to the peritoneum, that lining tissue on your organs, you've heard our speakers earlier touch on this, cytoreductive surgery and HIPEC may be offered. As many of you know, that means that all visible cancer in the peritoneum is removed and then heated chemotherapy is placed inside the abdomen to kill microscopic disease. And the tip I have for you to set your expectations for surgery is to ask your surgeon where your cancer is inside of your body. We try to figure that information out as well as possible. And as you've heard, sometimes the scans and things can not tell us the whole picture, but it's important to understand that from your doctor as much as you can. So if the cancer sticks to your peritoneum, this can certainly be removed by a highly trained cancer surgeon without lasting side effects. However, if the cancer involves other organs, it's important to understand how surgical removal of those organs will affect you both in the short term and in the long term. Additionally, don't forget to ask your doctor or your advanced practice provider about nerves or blood vessels that are close by, as surgery on these structures can affect muscle strength or sensation, sexual functioning, or pain after surgery. A few additional points. While thankfully the majority of appendix cancer patients will not need an ostomy during their cytoreductive surgery, we do discuss it often as a potential outcome. And this can be very emotionally distressing to think about having an ostomy. I have had patients choose not to have an ostomy over a surgery that could cure them of their cancer. So if you have advanced cancer and this is discussed with you, I really encourage you to educate yourself on this topic. You will find that while no one wishes for an ostomy, our cancer patients are often surprised by how manageable it is to live with, have a partner with, swim with, etc. And you can lead a normal life with an ostomy after surgery. You'll also hear a nice talk later during the session about advanced directives, which can be a difficult topic for some, but that we recommend all of our patients have in place prior to surgery. And then knowing what to expect after surgery, there are some major points I'd like to just make in terms of topics to prepare for before surgery. After a major surgery like cytoreduction and HIPEC, you should expect you'll have to return to see the surgeon, the surgical team for frequent rechecks. Because of the frequency of these visits, sometimes up to once a week for several weeks, we do strongly recommend to our patients, if you live more than 2 hours away, to find housing close to the hospital where you can comfortably recover and reduce your travel time to appointments. Your cancer team can certainly help provide resources prior to surgery to facilitate that. And then once you've gone through chemotherapy and surgery and perhaps more chemotherapy, ultimately our patients reach a phase of surveillance. And this involves coming in routinely every few months for scans and labs. But I think more importantly, this is a phase of time that allows you to refocus your attention from the cancer and back to you. And this is often a time our patients tell us they feel they've gone through a trauma because of their cancer treatments, or they find themselves now with anxiety that perhaps the cancer will come back, or they'll need more chemotherapy, or their body might change again after another surgery. And so each of these surveillance visits can really be a trigger that reminds you of that, and or at least brings back all of those anxieties and uncertainty about what the future may hold. I'm sure many of you who are listening have gone through this journey can relate to that. And you know, we did touch earlier on addressing emotional support early on. We might have missed that in my things cutting out, but you know, I'll stress again, I think it's really important to build your toolbox for how to manage these anxieties early. However, sometimes you just don't know until you've gone through it. And so I think this period of survivorship comes with that challenge. So many programs offer a survivorship clinic, which specifically focuses on those challenges and how to overcome them. One example of one challenge that I'd like to mention, because I think it can be very difficult for patients to discuss, is sexual function. It's an important part of your life and your emotional experience, and there are times that surgery or chemotherapy has impacted sexual functioning. So I tell you, if this is an issue for you, please start by asking your doctor or your advanced practice provider or your nurse about that. And during the survivorship period, focus on this part of your cancer journey. Focus on returning to a normal life, doing things you enjoy, spending time with people you love. Next slide. So at the University of Chicago, many of our patients come from a distance to see us for routine care, as well as a significant group of patients that come from all over the United States or internationally for a second opinion. And many cancer patients have multiple oncology teams, including a tertiary cancer center like ours, and then perhaps a cancer center that is closer to home. So to make the most of your appointment time with your oncologist, particularly when coming for a second opinion, come prepared. Stay up to date about your appendix cancer diagnosis. Ask questions so you know what your oncologists have been recommending to you. You are your best advocate. It's also helpful if you start building a record of your prior surgeries, chemotherapy dates, scan reports, pathology reports, tumor markers. You can bring those records to your appointment. When your oncologist or surgeon have all the information they need, that is when you benefit most from their expertise and their experience. I mentioned on the slide that recent imaging is critical. If you bring your most recent imaging on CD, your cancer surgeon will love it. We at University of Chicago believe that collaboration with all the members of your cancer team is important, but really the most important team member is you, so please stay educated and really take ownership of your story. For our patients seeking a second opinion, we have a number of ways to proceed as well. You may consider using our ECO program or Express Expert Cancer Opinion. This is a preliminary conversation with your preferred doctor to discuss potential treatment options, typically while we're waiting for your complete records to arrive, and then you would typically schedule a subsequent more formal visit after records have arrived, where you can have a more comprehensive and personalized assessment and treatment plan. Our international or distant patients may also choose to pursue a remote second opinion, which does have some differences from a regular office visit. And many cancer programs, including ours, are now offering virtual visits for our new and follow-up patients to assist with social distancing. Next slide. So just to wrap up, I hope this information was helpful for you. Ultimately, our goal is to help you manage your cancer and keep cancer from managing you. Please let us know how we can help. At the University of Chicago, we will put our full arsenal of resources to work to assist you through your cancer journey. Thank you.
Thank you, Emily. I think our next speaker is someone that at a very young age has had to navigate a new diagnosis of appendix cancer. I think Dr. Julia Kearney will speak, is a physician herself who has had a very complex healthcare journey, and I think this hopefully will highlight, how complicated the field is, even for patients that are extremely aware and involved in the field. So Julia, thank you for sharing your story today and for educating all of us about your perspectives.
Thank you, Dr. Turaga. Can you hear me? Okay, good. So hi, I'm Julia. I'm obviously a patient of Dr. Turaga. I live in Indianapolis with my husband. And I have either PMP or, depending on which pathologist you ask, stage 4 well-differentiated mucinous adenocarcinoma. So I was basically healthy until March. I had worsening abdominal pain, went into the emergency room, was like, I have appendicitis. They said, yes, you do. I got my appendix out and felt great. And then I went home and was like, I'm done, problem solved. I followed up with the general surgeon in 2 weeks after the appendectomy. And she told me that they had found a tumor on my appendix, which was very unexpected news. And she said it was something called a low-grade appendiceal mucinous neoplasm, or lamin. She'd only seen 2 before in her career, so she couldn't really tell me exactly what to expect, but she'd looked on UpToDate, and according to that, I needed a CT scan in 6 months because something had perforated, but she didn't think that it had spread. So I liked my surgeon a lot, but I also knew that she was not an appendix cancer expert. She actually worked at the same hospital I worked at. I'm an OB. But I began to do my own research. I looked at the ACPMP website, and I decided that I probably needed to get a second opinion just because it's such a rare diagnosis, and I didn't want anything to be missed. So I made an appointment with a big appendix cancer center, and by that point it was April, and COVID had hit, so it was a tele-appointment. And as soon as I logged on and started talking to the surgeon, I knew that something wasn't right. He said that they had reviewed my pathology there and that they didn't agree with the first read. So they thought I had a lamin, they agreed with that part, but they also thought that mixed in was some sort of adenocarcinoma. So at that point, I was faced with a decision. I could either do a CT scan in 6 months and sort of watch and wait if I believed the first doctor, or I could have a hemicolectomy to make sure that there was no cancer left, which is one of the hardest things as a patient, is this having to make these decisions, and you have different doctors maybe telling you different things. I trusted the expert at the center, and I felt that I would rather have a surgery and come out with finding out everything was fine than wait and find out later that I had something that had been missed. So I decided to do the hemicolectomy just to be safe. I went in for the surgery and I woke up about maybe an hour and a half afterwards. And I looked at the clock and I knew right away that it had been a really short surgery. So then I looked at my stomach and I realized he had mapped out his incisions beforehand and he hadn't used them all. So I knew immediately that something had gone wrong, and he had counseled me beforehand that if he saw that I had stage 4 disease, he was going to stop the procedure because he would not be doing me a service. So I knew at that point that I had stage 4, which I started to cry, and he came to the bedside and confirmed, yes, I did find pretty extensive disease along your diaphragm, so I didn't feel like it was the right thing to do because you need HIPEC. So that was probably one of the worst days of my life. I went home with my husband. We went on to Google, which I never recommend to patients, but I did it anyway, and didn't like what I saw. And we were facing a really hard next couple months. You know, obviously I was scared. I'm 31 years old and I had stage 4 cancer. And also my husband and I had just gotten married that year. We had lost a pregnancy right before I was diagnosed with cancer. So 2020 was not my year. And I was potentially facing a big surgery with the loss of maybe my ovaries. So potentially not being able to have children in the future, or at least not biological children. I was very lucky that my oncologists were so supportive of me pursuing fertility treatment and trying to do everything I could to preserve my chance to have biological children. So I did 2 cycles of IVF, and I have frozen embryos in a freezer somewhere in New York City that potentially, if everything works out, maybe I'll be able to use. And that was a huge source of hope for me. I'm on the appendix cancer Facebook group. I connected with other patients from around the world who had done IVF prior to their surgeries, and they sent me pictures of their incisions and then pictures of their children. And it made me feel a lot better about the thought that I could have a future that I wanted. So I prepared myself for surgery. I met with Jeffrey over the phone and in person. I was one of those patients who thought that they had a really healthy diet. And then when we kind of went through it, I wasn't really eating that healthy. I wasn't eating high protein. I wasn't eating nutrient rich. So I made a lot of changes prior to surgery. And the 4 weeks before surgery, I switched to a really nutritious, high protein diet. I was working out 5 times a week. I basically put myself on a health plan because I wanted to have the best surgery that I could. And I went in for surgery with Dr. Turaga. I was very lucky. I was able to go home on post-op day 4 afterwards. And it was a huge adjustment. You know, I had gone into surgery being able to run. The day I got home from surgery, I was so tired after walking 2 blocks that I literally sat down. And my sister was like, okay, we need to go home. But every single day you just sort of get up and push yourself and try and do an extra block, another mile, whatever it takes, more time in the chair. And by about 4 weeks out, I was feeling about 70 to 80%. And then by about 6 weeks out, I was feeling basically almost back to normal. So it was kind of amazing how quickly it returned. And now I'm in the survivorship phase, which is essentially managing, you know, my anxiety about scans and what's to come. I have a high risk of recurrence. I know that. But at the same time, I have to live my life. I can't, you know, sit at home and worry about what's to come. I have to get up and go to work and move forward with the things that I want to do. So I'm very happy to be here. I'm an open book. So if any of you have questions that you want to ask me, I will literally answer anything. And if you don't feel comfortable messaging me in the chat, you can find me later. I'm happy to answer any questions. A lot of patients were very honest with me, and it helped me to hear what they had gone through. So I want to do the same for others. Thank you guys so much.
Thank you, Julia. That's, you know, it's obviously a big life change for you. And I think it's, you know, it's important for all the patients on the call, you know, to remember that as a community, as we talked about in the main forum, you know, we're, as a group of physicians treating patients, we're close and we want to do better. But I think similarly, you know, patients and caregivers can support each other in trying to make the right decisions, you know, especially complex decisions that there may not be a right answer, you know, things like fertility, things like, you know, how do you think about these things? And even we don't know the answers, but sometimes I think, you know, support groups can help. So I don't know if any of you have any questions about that. I don't see any questions specifically right now, but if anyone wants to share, or maybe Carolyn, if you want to make a comment or two about support groups and ACPMP and how do you think about that?
No, first, I just want to thank Julia for sharing her story. I think it's just really, this is the one sad thing, other than I don't get to come visit you guys in Chicago this year, is it does help to meet patients in person. And I'm glad that we're able to meet virtually and share stories and help each other out. So just thank you for that. We do have on the ACPMP website several different options for support. The Facebook group that Julia mentioned is definitely the most active, but if you're not a Facebook person, there's lots of other options. We're going to be starting an ACPMP Patient Advisory Council this fall, and one of our initiatives with that is going to be having the Advisory Council representatives set up local, eventually hopefully in person, but at first Zoom meetings with local other appendiceal cancer patients in your local area. So you'll have sort of a more local network of support that won't just be online. So we're really looking forward to that.
Great. I think there's a nice comment from Andrea in the chat about the high-risk surveillance stage, and it feels like wearing a heavy backpack and never knowing when it'll be open or added weight to, or even have weight taken out. I think that's very nicely put. But I would encourage all of you to keep sending in the questions. I think it's a nice segue into our next set of speakers. We have Jeffrey Whitridge and Maria Alvarado. Jeffrey is our dietitian. You already heard Jeffrey speak a little bit during the open forum. He's a clinical dietitian. He's had 2 decades of experience in oncology nutrition. He enjoys his life with going to farmers markets and sourcing out fresh local produce, cooking, traveling, strength exercise, and he loves eating. And so I think he shares a lot of our patients' stories, and he's able to help them through their journeys undergoing CRS and HIPEC. And Maria is a physical therapist with her doctorate at the Massachusetts General Hospital. She has worked for many years at the Pre-habilitation Institute at Shirley Ryan, and has been working with us very closely in pre-habilitating our patients, which means getting them ready for surgery. So Jeffrey and Maria, you guys are up.
Thank you, Dr. Turaga. Thank you for the ACPMP for having us speak today. And today I just wanted to take a little bit of time to talk about kind of pre-habilitation, nutrition, and you kind of heard it firsthand. But before I get too far along, I just want to kind of acknowledge that, you know, here at the University of Chicago, we have this community garden, and I love to talk about food. So this is just a quick kudo to our garden committee here on the clinical nutrition team for raising almost 1,400 pounds of fresh produce, which weekly goes to our supportive oncology program here. But you've heard about patient navigators, and I consider myself to be kind of a nutrition navigator. As you heard from Emily, I'm part of the other team, you know, in terms of nursing physician assistant and also the physicians in terms of kind of navigating for the patient in terms of what they need. But as you heard from Julia, really my role is to get you ready for that surgery. Oftentimes patients can come to me and I already know what's kind of going on in terms of how to assess them. And more often than not, patients, whether they've had chemotherapy beforehand, actually know how they're doing. And what we do is we put a plan in place to get them ready for their surgery, which you heard, which usually takes about 4 to 6 weeks. We usually will try to address some of the major things that are the barriers for appetite and intake, whether that's just a lack of appetite, early satiety, fullness, nausea, vomiting, as well as changes in bowel pattern. And that's where kind of what we call a individualized nutrition prescription comes into play. When I was working with Julia or all my patients, what I try to do is find out how much information they want. Some people want less, some people want more, but usually what we try to do is kind of focus on high protein eating to make sure that we're protein loading before the procedure so that this procedure can go as well as possible. And I think you hear this often, all the time, which is we're here to try to get your best kind of surgical outcome. And then after the procedure, what we tend to do is follow the patient for surveillance or survivorship eating. And that usually can last from anywhere from certainly up to a year, where we're working with a patient and trying to improve and improve their eating style and their lifestyle. What we hear in clinic a lot from Dr. Turaga is that you're going to take about 4 to 6 weeks to recover. And that's really where I'm trying to minimize that weight loss that might be happening after your procedure. And then the last kind of thing that I was going to try to talk about was this food as medicine. And this is really kind of the information about survivorship-based eating. We had some questions earlier, and you know, this is where I try to individualize that plan of care so that I get you back to the healthiest diet as possible. It certainly can be a transition from the first 4 to 6 weeks after your procedure to your long-term goals of where we see you in a year from then. So really working with the physical therapist, the team, the nurses, the physician assistants, and the doctors, my role is really just to get you in the optimal shape as possible so that you can have your procedure and be able to walk out as quickly as possible. I'm going to end just a few minutes, little bit early and turn it over to Maria. Thank you.
All right, hello everyone, I'm Maria. I'm a physical therapist on the team. Just wanted to kind of talk with you guys about the role of physical therapy in prehabilitation and with abdominal surgery in general. We work mostly in the outpatient clinic doing assessments to make sure that we're minimizing any complications. First of all, making sure what kind of condition you are in going into surgery is very important. Being in the best physical conditioning leading up to a major surgery tends to improve your outcomes on the other side. So it's important to stress aerobic exercise, aerobic training if possible, before and after surgery, but predominantly before, to build your reserves, so that during that 4 to 6 week recovery, like Julia said, you know, you're going to have some difficulty getting back immediately to your pre-surgical level. So you want to start training back into that slowly, but maybe under the supervision of a physical therapist. In terms of prehabilitation in general, we do physical examinations on patients in the clinic, looking at functional strength, looking at your inspiratory muscles, meaning how you can do diaphragmatic breathing to help get your abdominals moving again after surgery, and then resistance training both before and after surgery. Before, to build up that muscle bulk, that's where we work a lot, I think, with Jeffrey and in nutrition, and making sure that you're getting that high protein diet to make sure that you're building muscle and or preserving muscle during your recovery. But we work very closely with all the members of the team, really closely with Jeffrey in optimizing nutrition, because you can't really be exercising and building muscle and building endurance without proper nutrition. I think that's the majority of it. If I'm open to questions. The other thing that we do is provide patients with exercise handouts. This is an example of what we do and give to patients preoperatively, making sure that you are monitoring your fatigue, your sleep habits, and engaging in aerobic exercise, strengthening exercise, as well as flexibility exercises. I think it's important from a preoperative and a postoperative perspective. We sort of screen patients in the clinic, but then we help refer you to therapists more locally. There are oftentimes symptoms that can occur after surgery. One would be pelvic floor dysfunction, pelvic health with regard to bowel bladder control, but also sexual function, that we have physical therapists throughout the country who specialize in those areas and can help to get those locally as resources for you. I am also a certified lymphedema therapist, because if there is lymphatic involvement and surgery that damages the lymphatic system, there's also specific therapists for that to help control any swelling, teach you self-management techniques. But otherwise, the type of exercise that we encourage people to do is the type of exercise we would encourage anyone to do. When you have a cancer diagnosis, it really doesn't change how you're pushing your body. You're just having to monitor and listen to your body a lot more so and be in touch with that, or have a professional like a physical therapist to help supervise that and help you push yourself along the road to recovery. So be sure to be reaching out to physical therapists either in our clinic or in your own setting. Thank you.
Great. Thank you, Maria and Jeffrey. Maria, let me ask you this, and I'm certainly guilty of this. So, you know, most people, I think, you know, obviously after the surgical event and it's a little bit later, it's always easy to not exercise or not do something. What are simple things that, you know, folks can do in their day-to-day lives that, you know, can certainly help them in the survivorship phase?
Absolutely. I'm a big fan of using your own body weight to do exercise, or using your own environment. I think especially in the COVID-19 time, gyms really aren't an option for a lot of people, particularly people undergoing cancer treatment. It's not a safe option. So I think just calisthenic type exercises around your own house that can be very difficult, like squats, lunges, bridging, which is lying on your back with your knees bent, sort of lifting the pelvis up into the air, but just using your own body weight to do strengthening exercises. And they really can be endurance exercises as well. If you do them at a higher intensity, you can get your heart rate up if you do them in a sequence. I think maybe push-ups and dips and things like that might be a little bit more vigorous, particularly after surgery, but I think they're very effective. And then in terms of cardiovascular exercise, it depends on what kind of shape you're in. You know, for some people, just a vigorous walk around the block or a vigorous march up and down the stairs a few times can get your heart rate going. For cardiovascular exercise, you obviously want to have it sustained. So a long walk or a stationary bike ride, those types of things, working your way up from 5 minutes and getting your heart pumping quite a bit all the way up to 30 minutes, but gradually increasing it over time. I know a lot of people have had to invest in home exercise equipment this year. So good time to use it.
Great. And let me ask you another follow-up question. You know, we heard Julia describing her physical activity, and, you know, obviously she's a superstar athlete. So I think not everyone is like her, but how does a patient know if they're ready for surgery? Like, should they be able to do a certain set of tasks you assess, or how do we, you know, outside of the physician, what can patients look for to know that they're ready for surgery or not?
Yeah, I think the basics would be if you can tolerate a vigorous 6-minute walk. That is a test that we oftentimes do. Is called the 6-minute walking test, where we have patients walk up and down the hall at their fastest pace to make sure that they can have the endurance to be able to do that. Another simple test that we perform is having someone getting up and down from a chair 5 times in a row as quickly as possible. That's a good test of your functional strength if you don't have the ability to get up out of a standard hard chair without using your hands. It's often an indication that you've lost a good amount of strength and would benefit from intervention to be able to improve that, to be able to tolerate surgery a little bit better. I think this is a tricky population because a lot of people really are very healthy, like Julia going into this, that a lot of times they don't necessarily have a lot of impairments before surgery. But if you do have difficulty getting around, getting out of the chair, being able to walk a short distance, that we would need to do some rehabilitation before surgery.
Great.
Otherwise, afterwards, just returning to your normal activity.
Great, thank you both. I think we'll have some time to chat about, you know, foods to eat. I think I keep wondering what are the best things for us to do, and Jeffrey obviously does a lot of cool new research on this. So I think hopefully we'll have some time to chat if there's questions. I think Emily just answered some questions that Cheryl had in the chat. But I think we'll get moving and we'll see our next 3 speakers who are going to share the next few minutes of time. And so the 3 speakers coming up are Enal Hindi. Enal is our senior research coordinator in the Department of Surgery, who has worked extensively with us in our clinical trials for peritoneal metastases with both imaging as well as with the 5-HMC studies. Sandy Clark is a nurse who has joined us as our care coordinator, who has held many positions over her long career, and including in hospice as well as in coordination and marketing, and she's our patient care coordinator. And then Pujitha Kallakuri, who is a healthcare administration professional, who was responsible in part for the symposium and has been the glue of our program. So I think all 3 of them are going to speak a little bit about things to think about.
Thank you so much for allowing me to speak today. I really appreciate it. And thank you for all of the speakers, for all the very informative speeches everyone gave. So today I'm going to talk to you about clinical research, and essentially I'm going to give just a very broad overview of what clinical research is and the importance of clinical research with appendiceal cancer. So clinical research is the medical and or scientific research that involves people. And although there are 2 types of clinical research, under one is the umbrella of observational studies, which essentially follows people in a normal setting and records information from either medical tests, surveys, or questionnaires. And the other being the bigger umbrella of clinical trials, which has the 4 phases of 1, 2, 3, and 4, and they progressively assess the efficacy and safety of either a medical approach, drug, or diagnostic test, and progressively increases the number of people from 100 in phase 1 to up to 300 in phase 2, and 1,000 or more in phase 3. And then in phase 4, where that medical approach is being marketed, we'll go into the thousands. Next slide, please. And so clinical trials are very important. As you can see, that clinical trials are essentially the reason why we have a lot of the drugs that we have today. They enhance the delivery of chemotherapy, There's targeted therapies and combination therapies. And I will talk about the importance of clinical trials and society. Next. So if you want to take a look at clinical research from the perspective of how important it is and how it relates to you, you can think of it as what it can provide. And in terms of discovery, what I would like for you to think about is that new information is essentially needed. With discovery, not only is new information needed, but we need to, because these tumors are very rare, we need to build on the current knowledge, and we need new tools to address these rare diseases. From a societal point of view, we need to think about preventing and treating illnesses that are extremely rare and that we don't know much about. Improving the quality of life and helping people live longer and healthier lives also bring it back to the health of you. Essentially helping you improve your life with your diagnosis. And as Julia kind of alluded to, like, you know, coming back to every day-to-day things, doing day-to-day things with an improved function. And that's really the importance of clinical research. What can we offer that's new? What can we build on? How we can improve society and how we can essentially improve the quality of life with your diagnosis. Next slide. I do want to emphasize that because these tumors are rare, they are extremely difficult to treat. And as we heard from patients' questions, and as we heard from doctors and scientists today, we really do need to advocate for each other. We need to listen to each other's stories. We need to participate in symposiums like this, and we need to ask questions about clinical research. Which clinical research is right for who? And we need to advocate for each other in a way that can bring more information to scientists and doctors, that can bring more information to treating these tumors, and essentially improve the quality of life. Next slide. I also want to emphasize that, you know, as these tumors are rare and more information is needed, there is so much more that we can learn. And a lot of people ask, you know, as part of my role as a clinical research coordinator, when I enroll patients into clinical trials, it's very humbling, honestly, and a lot of the patients, to hear them say that, you know, what can I do to make sure that no one else goes through this? How can I help someone else in the future? Because what I've been through was really tough. And if I could participate in something that will alleviate even a little bit of pain for the next person, it's worth it for me to be in this trial. And I think that's part of the reason why clinical research is so important. It really brings better new treatments, and it affects many more patients than today's population. Next slide. Thank you, everyone, for your time. And I just wanted to share just a few references on, if you really are interested in what clinical research is and why you should participate in them, and just a general overview on nih.gov. Thank you.
Great. Thanks, Enal. Sandy, I think you're muted.
Thank you, everybody, for the opportunity to be able to speak briefly about legal documents called advance directives. Hopefully, you'll see that this information is helpful for all the symposium attendees, because nobody can predict when a serious illness or an accident might occur. And when or if it does, you may need someone to speak on and make healthcare decisions for you. So if you plan now, you can increase the chances that the medical treatment that you will get will be the treatment that you want. These advance directives forms allow you to spell out your decisions about end-of-life care ahead of time, or medical treatment that you desire in the event that your health is compromised. They give you a way to tell your wishes to your family and friends and healthcare providers, and who you want to make decisions for you when you can't. And this helps to avoid confusion later on. Next slide. There's several different advance directives, such as living wills, durable power of attorney for healthcare, also known as the medical power of attorney, post, and then also DNR orders. Many healthcare providers and professionals would really like to know that there's at least a power of attorney for healthcare on file. So I'd like to spend just another moment more on the power of attorney for healthcare. A power of attorney for healthcare does not require an attorney, but it does require the signature of a witness who is a non-family member. And the power of attorney for healthcare is a form that you have identified someone to speak on your behalf if you can't. And with that said, there's some factors that you want to consider when choosing a representative. That representative should be anyone that you can trust, who's at least 18 years old, your next of kin, another family member, or someone else. And also ask yourself these questions in selecting a representative. Are they assertive? Are they someone who's comfortable speaking with healthcare providers and who can advocate for you? Are they comfortable about talking about death? Do they live nearby? And will they respect your decisions? So in closing, I just want to say let me just move to the next slide. These are some websites that you can, for resources to be able to get a little bit more information about advanced care directives. So in closing, I just want to end by saying that death finds all of us eventually. We can't prevent it, but we can direct how we would like our final days to unfold. Advanced directive planning is about making thoughtful decisions and choices now and putting them in a written directive and discussing those choices with others. And I've just found that these advanced directive forms can serve as a way to have that important conversation with your family and loved ones and allow you to think about what matters most to you. So I'm a resource for you. If you have any questions, there's my email address at the bottom, and I'd be happy to speak with you and then and direct you for more information. Thank you again.
Thank you, Sandy. Good afternoon, everyone. I just wanted to take a few minutes to talk to you about the importance of getting connected. Oftentimes, receiving a cancer diagnosis can be really overwhelming and isolating, but the importance of highlighting some of these resources and groups that you can get connected to is one, to really extend your care team and your support team and know that you are not alone in this process. Part of also getting connected is ultimately being more educated and empowered about your disease, and then also being your best advocate. So what I really wanted to do was highlight 4 different areas, both within and outside your healthcare institution, that can help provide that assistance and guidance. One is, of course, patient advocacy groups. ACPMP, for example, and the symposium that we're on. It's a forum where patients can meet their peers, prioritize what's important to them, and highlight the research and the needs that they have as a community. The other are probably groups within your own town and your own area. In Chicago, for example, we have a group called Immerman Angels, which provides one-on-one support for patients, and it can be very therapeutic sometimes to really talk to somebody who understands what you're going through. And obviously, social media is one of the other groups that can really be leveraged to provide that community and that support. Within healthcare institutions, oftentimes you'll find a supportive oncology services program. We did touch on that a little bit today, but this includes social workers, physical therapists, nutritionists, palliative care and pain management, and just overall different individuals who, as you voice concerns, can help pinpoint and provide the care that you need. And finally, I want to emphasize financial counselors and teams. Going through treatment can be very tough, and the added stress of financial concerns and what that burden can be extremely aggravating to most patients, and that process can be long-winded. But the good news is that most healthcare institutions and administrative support within your cancer centers will have counselors and teams to help guide you through that process. Again, I just want to emphasize that you are not alone in this process, and adding as many members to your care team as possible are going to help providing you with that support system to really tackle this obstacle. And thank you again for having me speak.
Thanks, Pujitha. I think we're up on the hour, but I did want to emphasize one of these points, which is the fact that financial support services are often available at many cancer centers. It's difficult to access them. They're not routinely offered to patients, but we do know that the toxicity of cancer care, getting your scans in survivorship mode, getting insurance, navigating insurance companies, HMOs, they can all be very complicated and can certainly act as barriers when you're already dealing with a tough cancer diagnosis. So I think, you'll find help obviously at your institution if you ask for it, but then also I think, groups such as ACPMP will also be able to guide you to resources. There's big resources from like the American Cancer Society and other societies that help patients that are navigating these waters. So I think I think we're over, but Carolyn, I don't know if you had any comments or closing remarks.
No, I think we covered all the questions in the chat. So I just want to thank everyone for presenting and thank all the attendees. And hopefully we'll be seeing each other in person next year.
Well, thank you all, and you all have a safe evening. Carolyn, are we all going back to the main session or are we done?
Nope, we're done. We're done. So thank you everybody for participating, and the recordings will be available hopefully within the next few days. If you want to go back and review anything, we'll let everybody know where to find it.
Great.
Thank you.
Thank you all.
Thanks everybody. Goodbye.